Hello and welcome to this special edition of Cystic Fibrosis Review. I'm Peter Mogayzel, and I'm joined today by Dr. Peter Sly, who's Deputy Director of the Queensland Children's Medical Research Institute in Brisbane, Australia. We're recording this interview at the 36th Annual European Cystic Fibrosis Society Conference in Lisbon, Portugal. Welcome, and thank you for joining me.
Thank you for having me, Peter.
So I know that inflammation is very important in early lung disease. Can you tell me about the work you've done on looking for biomarkers of early lung disease?
Yes, Peter, the data that I presented here and that comes from work that's been done over a period of time, we set up an extensive early surveillance program in Western Australia when I was there in the anticipation of the introduction of newborn screening in about the year 2000. Mm-hmm. We were the last state in Australia to get newborn screening, but we'd noticed that groups in Melbourne and other groups had started doing bronchoalveolar lavages in children and looking at early infection and inflammation, and we thought that with the introduction of newborn screening we had the opportunity to start something from the beginning to go through. Mm-hmm. So we started this program in about the year 2000, and in 2005 with funding from the USCF Foundation we extended this program to Melbourne and we added CT scans into the program as well. But in a nutshell, what we have found over that time is that CF lung disease begins very early, and the very early markers of this are early neutrophilic inflammation, particularly the presence of neutrophil elastase activity in the lung, and that's correlated with early structural damage, so the antecedents of bronchiectasis with dilation of airways and gas trapping that you can see on a CT scan. And the data that I've presented here and that we've published recently shows the role of the neutrophilic inflammation and how that really is the critical event that leads to the onset and the establishment and the progression of lung disease in infants and young children with cystic fibrosis.
And how does that inflammation or the presence of neutrophils relate to infection in the lung?
That's an unresolved question. Our surveillance program is done time when the children are well, so that it's not the time you expect to pick up infection, and we're not well suited to looking at viral infections in particular. So when we see inflammation in the lung and don't see infection, we can't say that it's not because the kids had a cold a couple of weeks ago and this is the residual. But with that caveat, we do see inflammation in the presence of infection, obviously, but we also see inflammation when we are not able to detect infection on any occasion in these children. And so that it's an unresolved question as to whether the inflammation can be a primary event, and there are many reasons in the CF lung why inflammation may be a primary event, or whether it always follows infection. But in some ways that's not necessarily the right question, because both are important. Neutrophilic inflammation per se is important, and the presence of infection per se is important, and the two of them together are worse.
How early did you see evidence of inflammation?
Our program starts from birth. The diagnosis of CF in Australia is by newborn screening, and it's usually around about 6 weeks of age when the kids are diagnosed. And our surveillance program picks them up from this age, and the first assessment occurs around about 3 months. The median age of our first assessment in over several hundred children is about 3 months. And on those BALs at 3 months of age, about 30% of children have neutrophil elastase activity, free activity detectable in their BAL. They have higher neutrophil counts than we would anticipate. We do have to be a little careful because we don't have a lot of good data from normal 3-month-olds. There's not many bronchoscopies and BALs done on healthy 3-month-old infants for obvious reasons. But the neutrophils are higher than we would anticipate. And we see that as the children get older, the number of neutrophils increase, the inflammatory cytokines increase, and the evidence of structural damage, dilation of airways, gas trapping on the CT, increase over the first few years of life. So it starts very early. We can detect inflammation, we can detect infection, including with Pseudomonas at 3 months of age, and this is related to the development of structural lung disease.
Is it possible to predict or develop a timeline from the time you develop inflammation to, or see inflammation to when you actually develop structural damage?
Well, what we did in this one particular study, we looked at the children at 3 months of age and dichotomised them based on the presence or absence of neutrophil elastase activity in the BAL. If they had neutrophil elastase activity, then their median age of developing bronchiectasis was just over 1 year of age. If they didn't have neutrophil elastase, it was about a year later.
And that's a significant difference.
It is. And it indicates that if we're going to introduce treatments to prevent or delay the onset of disease like bronchiectasis, it really has to be done very early on, and in my view it has to be done from diagnosis.
How would you suggest that we use this information in clinical practice?
I think that the implications for clinical practice right now come from the fact that we can see this inflammation, we can see infection in the lung in the absence of clinical symptoms. So for the families and for the physicians and the teams looking after these children, just because they don't have symptoms doesn't mean they don't have disease brewing. So I think vigilance is the key to maintaining good lung function. In the future, and hopefully the short-term future, we will be able to develop some markers that will tell us more accurately, without having to do a BAL, whether what's going on as far as the neutrophilic inflammation, and we've got some indications where we should go there. In the more distant future, I would expect that we can use this information to select children for particular clinical trials. If neutrophil elastase is a key, there are neutrophil elastase inhibitors which are in development. There are treatments like azithromycin which are thought to have anti-inflammatory activities, particularly anti-neutrophil inflammatory activities. And so we'd be able to build up a criteria, if you like, an entry criteria for clinical trials based on some of this information to see how we can really make an impact on preventing bronchiectasis. But we're a little away from doing that just yet.
And you had mentioned finding something as a biomarker that was not as invasive as doing BAL. Are you thinking of a serum biomarker?
Well, children don't like have blood tests any more than they
That's
like
true.
having anaesthetics, or their parents like having anaesthetics. So what we're really looking for is a urinary biomarker. I can't tell you exactly what it is yet, but I have an indication of where we're going to go. We have seen that the same sorts of biomarkers that we can see in the lung may well be present in the urine, and we have the right sort of data to be able to validate some of these. We have, in our surveillance program, we have matched BAL blood and urine samples. We have the clinical information. And there are a couple of biomarkers of neutrophilic inflammation that we're actively chasing. But one of the things we have found so far is that we cannot rely on the results of studies in adults or older children with established disease, because the associations and the relationships with the markers of inflammation are different in those who have established disease than those who are starting out, if you like, and are just beginning their track down the disease process pathway.
No, that certainly makes sense. I would think that established disease would have a much different pathology, a much different set of biomarkers and inflammatory processes that you could find.
So I guess ultimately what we would like to have in the future is the equivalent of urine dipstick. Kids come in, have a urine sample taken, have this rapid screening test that shows the presence or absence of these markers. If they're present, they need to have further assessment. If they're absent and they're well, things may be going well. So that's where we're aiming for, but we're quite some way off that. But you've got to aim.
No, that's fabulous. As you know, objective measurement of lung disease is so difficult in young kids, and being able to identify who may be at risk for that is even more important. So thank you very much for joining me today and talking about your research.
My pleasure, Peter.
And thank you for joining me on this special edition of Cystic Fibrosis Review.